so much. All right, so next segment we're going to get into is across the board for upper cervical doctors. This is something, an area that we should dominate. This is a huge, huge concept that, frankly, once again, up to about 3, 4, 5 years ago, I didn't even really realize. There's a lot of discussion being made right now about the health of the brain and its connection to the upper cervical spine. So we start looking at vasculature, just some basic principles, basic things. So obviously, blood flow to the brain through arteries, from the brain by the veins. So carrying blood to the brain, internal external carotids, and coming back internal external jugulars. Those are our primaries. So when you see a study that comes out like this, where it talks about internal jugular vein blood flow in multiple sclerosis patients. And let's see, this was 2014. They found out of 58 patients that were analyzed with MS, ages 18 to 60, that 63.5% of them had higher hydraulic resistance of the cerebral venous drainage system, meaning the veins were not draining as well. It's quite interesting when you look at the location. This wasn't in that study. This was different charts I pulled out on MS. When you look at the prevalency of where is multiple sclerosis occurring most, in the U.S., it's above the 37-degree parallel. So it's in the colder states compared to the southern states. The prevalency is twice as much in colder areas. Now that wasn't part of the study. That was a separate thing I was looking at even just a few days ago. I was like, wait a second. And you know, when you start to put your attention somewhere, all of a sudden God and the universe start to show you more. So I was looking at, well, internal jugular vein, backlog the cerebral venous system, backlogging it, colder areas, I don't know. It's just interesting. And then you start looking at the world dynamics. Countries with the highest prevalence of MS. They're all cold countries. And then you start looking at this other one. This is the highest prevalence of MS. 85% of the world's population lives between the 40th parallels, north and south. And yet the highest prevalence is outside of there. And a little bit like 3 days ago, I'm like, what? How have we not heard this? Well, because we're not all focused on MS. I get it. I get it.
20 years ago.
But, wow. So, internal jugular vein, how does that involve this drainage system? Well, let's look at some more studies. So, this is a study out of surgical neurology from 1999. Compression of the internal jugular vein by the transverse process of the atlas as the cause of cerebral hemorrhage. So what this is, do you guys, I forget the doc who did this, but do you know why we were able to start saying, pinched nerves can kill you? There was a guy who did a dissection of cadavers and found that there was a high prevalence of which organ was dysfunctional compared to which spinal nerve root was encroached upon. Remember there was an atrophy of the spinal nerves? I think it was the Windsor autopsy, is that right? And so at that point, when they did autopsies, they were able to find that there was atrophy of the nerve root exiting the spine. And then they, after assessing that and recording that, they then looked to see, well, what organ does that nerve go to? And then they looked to see what the person died of. And over 90% of the time, it correlated that the organ that dysfunctioned, that cost them their life, had the nerve that controlled it being compressed or atrophied at the spinal level, which led all of the chiropractors to say, there's objective proof that the alignment of the spine and the nervous system's output can affect your existence, much less quality of life. So this is actually an autopsy study. And this guy found that in every specimen where he looked at the transverse process in the vertebral artery and the internal jugular vein, he found in every specimen the posterior wall of the internal jugular vein rested against the transverse process of the atlas, as the vein descended immediately below the jugular foramen. So in every specimen, it's sitting there right on the front of the atlas. In 14 of 36 specimens, the transverse process indented the posterior wall of the vein, causing the vein to be slightly or moderately angulated as it descended across the anterior surface of the transverse process. 3 veins were severely kinked as they descended across the transverse process of the... I always just love reading atlas and medical literature. I don't know why. That's right. We're talking about us, talking about our atlas. Conclusions. Obstruction of flow in the internal jugular vein at the site where the vein descends across the transverse process of the atlas is a likely cause of venous hypertension that has resulted in the cerebellar hemorrhage reported in numerous cases after supratentorial craniotomy. Very interesting. So now we've discussed how in MS people they were saying, well, the vascular flow is obstructed, backlog of cranial hypertension. And now we're seeing, hey, jugular vein on the front of the atlas, indenting the vein, affecting people vascularly. That's not even discussing part of this little diagram that isn't diagrammed. Styloid processes. Right here, and right here. So right here is a little window of discussion. Styloid processes. We briefly touched on this with you when we went over some statistics earlier. Dr. Bulow, unfortunately, really unfortunately, was short on time at the end and didn't get to show you a couple of cool styloid interactions, which he and I were joking back and forth. I'm like, don't steal my thunder, Ann. Don't steal my thunder. He's like, I got a cool case I got to show. I'm like, well, if you can squeeze, maybe get... So, I'll try to give you a little more time after this time. So you may notice that's why when I stood over there, and he's like, oh, I'm running out of time. And he started to go into it. I'm like, oh, no, out of time. Styloids come off the bottom of the skull. They're an attachment site for the hyoid bone and the connecting soft tissue that connects right onto the styloid process. Here's atlas. These are styloids. Just one example of many. Here's another example. There's styloids. When I was going over data with you guys, I said, we were talking about the prevalency of having elongated styloids. Elongated in the medical literature is if it's longer than 1 inch. And I'll show you, they call it something called Eagle syndrome. I don't really care if it's 1 inch, 1 1/4 inch, 1 1/2 inch. What I care about is if it's going down to the atlas level. Because if it's going down to the level of the transverse process of the atlas, then we have a potential complicator to this person's function when their atlases are out. They can be classified as elongated or as a pseudo-articulation, whereas this soft tissue is coming up and inserting here. It forms almost a joint. Or they can be like segmented calcifications. So we take our x-rays. And we're going to study our x-rays. And I always ask you guys, please look closely. Don't rush your x-ray analysis. We often get busy in practice and we're just trying to get the vectors so we can go put it in the magic machine and push a little click button. There is so much information behind the details of the mechanics of the misalignment, how you position a patient, and sometimes even functional complicators, anatomical complicators that are staring at you, begging you to see them. But we say, the curve's pretty good. No major translations, disc spaces, pretty good. Yeah, okay, not too bad on the side here. And we'll study the atlas and see how it's out of alignment. But if I just ask you to look a little closer, right in here, and see this white line coming in front of the atlas. And you look on the sides of the atlas over here, you see a white line coming through here. And a white line coming through here. You can even see one of those breaks right here. But this is actually a case where it's not a pseudo-articulation. There's elongated styloids, and that's actually a fracture. That person went to an upper cervical doctor, I won't tell you what technique, and the doctor did not recognize there were styloids there and did a manual adjustment on a sideline position and cracked her styloid. This is a wife of a doctor that practices upper cervical, and they didn't know. And she knew she had some pretty intense pain when it happened, but nobody knew it was cracked. Yes?
Calcification and ossification are two different things.
Totally agree.
And I would think they look pretty similar though.
So we'll probably have to look into what trends might show whether it's calcification versus ossification. And you are like my segue guru. We'll get into that.
Reading your mind.
So we get our listings on people, and we automatically have our numbers and what we're going to do. Well, just don't forget to look to the sides of the atlas. They're staring right at us. Some people have said, well, no, isn't that part of the internal mandible? No, that's out here. This is inside. So black space, styloid, staring at us. Here's a zoomed in image. Can you see the styloid?
Yes.
It's right here. It's coming right through, staring at us. Sometimes you got to play with your contrast on your software to see it. But it's staring at you. Can you see it? Coming right through here. Coming right here. Just look for them. You guys are going to start going, oh my gosh. They're so common. There's another case. A little harder to see. This guy is a dentist. He actually, when you were bringing up about Dr. Schulten talking to the dental guys, this is a guy not from that group, but from a different group that an AO guy goes and talks to. And this dental guy came in for care. And at first, it's kind of hard to see. If you look closely, it's right here bending through. If you look at his frontal film, just remember, here's the atlas, here's the arm of the atlas. Just look for the line coming through. This one's a little harder to see than the previous one. This is probably one of the harder ones to actually see it. I want to show you a difficult one to see versus the normals. This is way harder to see than you're normally going to see it. They're way easier to see than this one. They diagnosed when a styloid process is longer than an inch in development. They call it the Eagle syndrome. The medical field's been diagnosed since like 1930, 1940. They saw this back then. The dental field will talk about it, and I don't know if I put it in here, but the dental field will talk about it for what complications it could have on discomfort of swallowing and pain, especially on flexion. So they talk about ways to surgically go clip them. They look at it as they're only concerned about if the elongated styloid process is causing neurological symptoms. So actually I'll read through. Eagle syndrome is a rare entity that causes recurrent throat pain, neck pain, dysphagia, or facial pain due to an elongated styloid process or calcified stylohyoid ligament. Clinical findings related to lower cranial nerve compression have also been reported. Carotid artery compression causes flow reduction, and carotidynia, or neurological symptoms, can be seen. Dural sinuses and the jugular vein can be compressed. The data of 5 patients aged between 22 and 68 years old who presented to the hospital, and I purposely highlighted this for our group. They presented to the hospital with various neurological symptoms. Why? Because we're subluxation people. No, the osteopaths manipulated for blood flow improvement. Chiropractors came along, no long levers, short levers. Not manipulation, adjustment. Not malposition, subluxation. And we're there for the neurologic reasons. So they presented with neurologic issues. The medical field started searching to see, hey, what's going on, and they happened to find these styloids. An elongated styloid process was caused, read this, an elongated styloid process caused neurological symptoms. This is how the medical field looks at it. Because what does the medical field not know how to find? Subluxation. So they said, oh, the styloid caused the neurologic problem. The fixed piece of bone that's not moving and has been there for how many decades is causing the problem now. 2 patients had venous compression by the styloid process, and the other patient had transient ischemic attacks due to internal carotid artery compression by that dang styloid process. Stupid styloid, it's the problem. American Academy of Neurology. Styloidogenic jugular venous compression syndrome. 2012. Looked at slowly progressive gait ataxia in a patient with sensory neural hearing loss, episodic headaches for 6 months. A dynamic cerebral venogram with extension and flexion views revealed severe bilateral internal jugular vein narrowing at the level of C1, C2, more severe with neck flexion, with considerable congestion of the paravertebral veins and spinal epidural venous plexus. I want you guys, especially in EPIC, that palpate the C2 DRG. Please remember what's being noted here. There's an issue going on that's causing considerable congestion of paravertebral veins and spinal epidural venous plexus. We're going to come back to this. Manometry study revealed an increased pressure gradient across the narrowing between the sigmoid sinuses and internal jugular veins, which was worse with neck flexion compared to neutral position. Russell, if I don't come back to it, ask me what you wanted me to ask you about neck flexion effectiveness, Doc. More severe neck flexion, worse with neck flexion. We're going to come back to that. Another group, American Journal of Neuroradiology. This is a very, very big deal, guys. American Journal of Neuroradiology did incidence of extrinsic compression of the internal jugular vein in unselected patients undergoing CT angiography. And this study is going to show us a lot of fun things. Okay, so just in their abstract write-up, moderate stenosis narrowing was seen in 33% of right and 25% of left internal jugular veins. Severe stenosis was seen in 24% of right and 18% of left jugular veins. So the right side was either moderately or severely stenosed. The right internal jugular vein was moderately or severely stenosed 57% of the time, versus the left was not stenosed as often. Got it? Memorize your data points, because we're going to come to a conclusion on this. So in their study, they found the right jugular vein and the compression occurring from that more common than the left side. Out of the different parameters they looked at, read what their third parameter was. The third parameter was the cause of the extrinsic compression. Styloid process, posterior belly of the digastric muscle, and the C1 transverse process. In all cases, the compression was caused by 2 factors. The posteromedial aspect of the compression was caused by the adjacent cervical vertebrae. What? Wait, what? Let me see. I must have misread that. The posteromedial aspect of the compression was caused by the adjacent cervical vertebrae, which provides a non-compressible structure against which the vein is pressed. Non-compressible, it's because the vertebrae is actually a bone. It's not soft tissue, it's hard tissue. So you couldn't compress the vertebrae, it's non-compressible, and it was providing compression of the vein. The digastric muscle, by the way, is right in here, actually right there. There's the stylohyoid ligament right there. Of the 108 consecutive patients reviewed, so consecutive patients, out of the 108, 49% were right jugular dominant. Only 19% were left jugular dominant. 31% were bilateral dominant. So by far, more people are right jugular dominant. Interesting correlation is that inside Sonus, I didn't give you guys all the stuff we're finding from Sonus. In fact, I can't give you all the stuff we're finding from Sonus. And I didn't know what the word savant meant.
You look it up.
I asked two people. But one of the things is we haven't even started touching the surface of the cross-referencing data points. Haven't even started it. Another whole segment of the cross-referencing of data, 82% of patients had inflamed DRGs, right? Inflamed on the right side, where over 50% of people are right jugular dominant. And they're already saying the C1TP can compress and cause the restriction of the vertebral venous plexus and the dural sinuses and the other things as well. So more people are right dominant. So even if you provided equal pressure, the right dominant is going to express right restriction. And we're not even done with their study. They actually are going to reveal more to us. Because if we cross-reference their study with what we discussed, do you remember which direction the atlas rotation more commonly was? What is it?
Right anterior.
Right anterior, left posterior, positive theta Y. 66% of cases had a right anterior. Right TP pushing forward into a right dominant jugular vein. And we have 80+% of people demonstrating a right C2 DRG inflammation more than the left. We now have a clue as to possibly why. And we never, ever knew that before. At least I didn't get told that. Because everyone's always like, well, why is it? You say it's swollen. Why is it swollen? Is it really inflammation? Because inflammation will take some time to go away. And I'd be like, yeah, but it goes away right after the adjustment. So if it was inflammation, gosh, it would seem to take longer. And when patients would say, if it's inflammation, why does it go away right away? They're like, yeah, I don't know. I have a much better idea now.
So what's the conclusion?
We're not done. The point is, whenever we're looking at studies, you're just trying to learn a little bit more. I don't know that anybody's going to come up with a conclusion in this conversation.
We won't.
We're just learning more. So what we can see, the points that are connecting, in one Sonus blueprint study, we're seeing 67% of people are positive theta Y, right anterior, left posterior. We're seeing that over 50% of the time people are right jugular dominant. We're also seeing studies that show when the TP is pushing into the jugular vein, it will compress it, creating obstruction of the cerebrovenous plexus. So it's all matching up with, here's the vascular compromise. That wasn't even talking about having the styloid in front of it, creating an anterior wall that when the atlas now turns and pushes into that artery or into the vein, well, now there's a wall in the front because people have elongated styloids sitting right there. So if the medical field doesn't know about the subluxation of the vertebrae, they just know compression's occurring, they'll say, well, let's just surgically remove the front wall. And we come along and go, just correct the subluxation. We found that, this is going on in their discussion, we found that extrinsic compression of the internal jugular vein is common in unselected patients. The most common causes of this, I love reading this, the most common causes of this are the styloid process or posterior belly of the digastric muscle, often adjacent to the lateral mass of the C1. They did say our study has limitations. And I love reading this. It's a retrospective series of patients with neurologic reason. Once again, neurologic issues are showing up. They're looking at it from a structural soft tissue. We're looking at it from a malposition. But they said they have a neurologic reason for being there. They also said, given the large number of patients in our study, we feel the incidence of jugular stenosis is likely representative of a larger cohort of patients. Then they talk about it is possible that turning the head may change the degree of compression. Where do epic clinicians in their exam protocol involve turning the head?
Strength test.
Initial exam.
In your initial exam, when we have the patient and we assess their strength factors and their muscle imbalances and their leg deficiency, and then we have them turn their head. And we see if it changes.
Let there be light.
And they turn their head the other way and we see changes. What are we inducing or releasing? Have any of you thought about that before? Because I'm like, oh, that means your atlas must be out. It's possible turning the head may change the degree of compression. Extrinsic compression of the superior segment of the internal jugular vein, all the way down to the level of C3, is a common finding caused by either the styloid process or the digastric muscle and the transverse process of the adjacent cervical vertebrae. Here's a study that was done in 2002, and they said it's a plan of internal arterialization of blah, blah, blah. It's going to be very technical terms. Let me read the part that's most important. Because it talks about it renders ischemic conditions, and then this vascular arrangement may contribute to a propensity to the ganglion. Listen closely. The vascular arrangement may contribute to a propensity for the ganglion to develop a compartment syndrome when subjected to compression by periformal degenerative or neoplastic space-occupying lesions. Are you hearing this? The ganglion itself can develop a compression syndrome, a backlogging of inflammation. So remember that this was the findings of the DRG being swollen on the right, the LPRA atlas, twice as common to cause inflammation. The right LPRA atlas, twice as common to cause inflamed right CT DRG. So when a patient walks into your office with chief complaints of head pressure and vision issues and dystonia, you might be thinking a little bit different. You might be thinking, I wonder if they have some elongated styloids going on there. I never used to think like that. I just be like, all right, let's get your atlas checked. I didn't think beyond that. Because just going to adjust people. This patient happened to live in North Carolina. She came down in July 2017. This was just recent, just this last year. In 2017, she had severe head pain. She was driving. She'd get double vision, loss of lateral eye movement. She was hospitalized for a stroke protocol. They said, you're having a stroke. But then they did the MRI of the neck and head, the orbitals, CT, vascular study, and everything was negative. Blood work was also negative. She went home. The pain got worse over the next 6 weeks. And then she came to visit us September last year. Wearing glasses like this or switching to a patch like that because her left eye wouldn't look left. She had double vision also in that eye. But she could move it into all the other fields, but she just couldn't move her left eye into the left field. So, of course, we're just atlas doctors, that's all. So we go ahead and go through our protocols. Found that her C2 was swollen, actually on the right side. Her upper extremity had less strength to it on the right side. It improved when she would turn her head. I don't know what that has anything to do with it. Her left low back muscles were tight. She had her leg length deficiency. Her left leg was in short. She did her marching test, and she'd go forward and turn left 45 degrees. Left head, tilt translation, elevated left shoulder. So I just took x-rays because we're just going to study her x-rays, get her listing, get her adjusted. And what do we see in the x-rays? Well, we saw, she lost her curve, bless her heart. Let's give her some exercises, or a towel roll, we'll get that back for her. She had some disc weakness. That's probably really what her major issue is. Let's just get right to let's go to spinal health discussion. Because we're chiropractors, so we need curve improvement. We've got to decompress the disc. Oh, her atlas also has to be out. We should do that too. So we start going through, here's calculations. Good, let's get her adjusted. So some of you might say, yep, loss of curve, degeneration, spurs. And this is what we're going to write in our nice little insurance radiographic reports. But if we would have looked closer, can you turn the light stop? Or at least turn down. She has the elongated styloid staring at us right here. and here, and here. Don't forget, all her medical reports said everything was normal. She already had the MRIs, the scans, the CTs, everything was normal. Blood work was even normal. But besides the loss of curve and the disc degeneration, she also had genetically elongated styloids, genetically malformed posterior arch insertion, so the inferior arch, where it inserts, that's the typical Grostic-based point to denote for the atlas plane. I couldn't use that. It was aberrant. I had to look at the overall bone. We teach you how to assess for that. So she had a genetic inferior arch insertion. Her C1 was laterally displaced 1.28 degrees to the left. It was anterior on the right. C1 was, so it was traditionally like this, okay? It went off to the right and anterior. So she was right anterior. C2 was 7.2 degrees posterior on the right. So she had her atlas was off this way to the right and forward. Her second vertebrae was opposite of that. What is that kind of a misalignment called? Counter-rotational misalignment, which we already talk about obstructing blood flow. We already talk about the vertebral artery. You know, how that's going to really wrench on that artery, not getting enough blood to the head. That's what we like to talk about. So she had a cumulative 11.62 degrees of counter-rotation between C1 and C2 with elongated styloids. So what it can look like when C1 gets rotationally out of alignment, it can put a strain on the vertebral artery that normally is not got much of an issue, can have good flow. You can start to crimp on it. Counter rotations, you can crimp even further. But we'll just look at the imaging that showed she was normal. And this is where it gets extremely fun. Dr. Beulah would eat this stuff up. All right, so here is an image looking through at the C2 level. This is the left side. In imaging, in the medical imaging, they always have the left on our right, okay? So her left side, now if we go back real quick, by the way, right to here. So remember, her atlas had gone to the right and anterior, and her C2 had gone to the left. So her C2 spinous had gone to the left. So she's twisting, and this is where you can see the vertebral arteries going through there. But her atlas on the right had gone anterior. So her atlas was this way. And you can see, here's how the vertebral arteries are here. Here's how they are here. We'd already say, well, maybe that she's not getting enough blood to the head. Well, maybe there's even more. Here's the scan of it where you can see it mid-cervical, how the vertebral artery is going through. You can see at C2 how twisted it is, and at C1 how it is. We're already thinking vascular concerns. This one actually shows the slicing where you can see the vertebral artery as it comes up and which direction it moved. Look how much torsion is occurring on those vertebral arteries. It's a lot. But her medical scans were fine. The radiologist looked at her brain and said, everything's normal. There's no issues going on with her. We don't know why your eye won't turn left. So let's look at their version of normal. Can you see the difference in pockets? Remember, this is her left side. Left side. Can you see the pockets, how they're filling? Look at the asymmetries. Fluid, fluid, fluid. Oh, this is all normal. Fluid pockets all over the place. Totally different than the other side. But it's all normal. It's just a slicing right up through the brain. You can see her entire left hemisphere is backlogging with fluid. But remember, the radiologist said it was all normal. So we did adjust her. We took the coordinates from her x-rays, set her up on the table, set her biomechanics with how we position her, calibrated the instrument with her coordinates, slid the vertebrae into place with sound wave. I think I missed it. Try again. The noise didn't happen. Anyway. Like we do. It's like, did it. It takes the third try with Epic for it to actually. So immediately after the adjustment, the leg length did balance, the muscles did relax, and the C2 DRG did release. Now she was like an inch short. For her to drop all the way an inch, that's a lot. You don't usually, I mean, you can see it come down a quarter, eighth, but I mean, all the way down, it's like, you start questioning whether I'm misreading something because that's a lot of drop. But when you correlate with the low back release and the DRG release, now your three parameters all said we have change. So all you're just looking for is it changing? Yes, sir.
I know it doesn't necessarily matter clinically for here, but did you get an accident? If the styloid is already there genetically, I mean, what prompted that atlas to misalign even more for the symptoms to, did she go over any, no, but the counter rotation's already there.
Well, no, but I'm saying, are you saying the trauma induced probably?
Yeah, like it started in July 17, but did she have a car accident?
I don't remember.
Did she get punched in the head?
I don't
She
remember.
told us the double vision just kind of came out of nowhere. Had she had an accident in the last 10 years or something? I don't remember. But to her, it had come out of nowhere. All of a sudden, she's driving home one day and her eye's not working.
Yeah, that's a good thought process. Just
Yeah.
what's the preemptory cause? I
Right.
don't know. So pre-post X-rays, we were able to get a 96% reduction of atlas laterality, and we were able to get a 38% reduction of the counter rotations, meaning we got C2 starting to come back and atlas starting to come back at the same time. That's usually considered pretty tricky. So that was effective, it seemed to be. Because she then, within 2 weeks, went from this to this.
No more double vision. Smile. Double vision gone?
I don't remember. So, since nearly 50% of patients, my font's terrible. Nearly 50% of patients have elongated styloids. Don't forget that. We already went over that data before. But since nearly 50% of people have elongated styloids, we found also, by the way, we did put in the, bless you, we did find there was no difference based on gender or ethnicity. But remember that we did find the prevalence of different ages seemed to indicate that the styloid processes were less common in people aged 0 to 10, only at 20% on average, compared to an average of 48% of people ages 11 through 100. So it's least common in the 0 to 10, more common after that, which we discussed likely indicates this is an ossification where it's just developing that long. The interesting thing, you guys know how you run into this where patients come in and they say, yeah, I have this issue going on and my doctor said it's genetic. And you're like, hey, well, when did it start? Like a year ago. That's been going on a while. I'm like, yeah, you're 50. What about the first 49 years? I mean, genetic, it's been there the whole time. Why are you possibly you really think it's genetic? That all of a sudden now it's just showing up. And you've had zero issues for 49 years and all of a sudden this styloid's the problem. Now, patients ages 51 to 60-year-old had the highest prevalence of the elongated styloids at 60%. Then we started doing some more cross-referencing of data points. We then took people who were complaining of headaches as their chief complaint, because we have that in SONUS as well. And now it starts to, well, we're not supposed to talk about symptoms. Let's just stop that for a second. Just consider this. People complaining of headaches, how often does that person have elongated styloids? How often does that person have counter rotations? How often does that person have counter rotations and elongated styloids? 49% of people with headache complaints have elongated styloids. 49%. 35% of patients with headache complaints have counter rotations of C1, C2. 44% of people that have elongated styloids also had C1, C2 counter rotations. And then when you look at it the other way, of people with C1, C2 counter rotations, 38% of them had elongated styloids. So you can have people that have counter rotations without elongated styloids, and you got people with elongated styloids without counter rotations. So when you're really looking at data, you have to bounce back and forth to see the picture of it. So going back real quick to this neurology, neurosurgery, and psychiatry, this is the age prevalence of MS. There's the chart showing how commonly MS is being diagnosed in people. Where is it peaking? Right here. Between 40 and 69. 50 to 69 is the most common. And look at the elongated styloids by age, the most common. I love looking at data. It is geeking out, but things come to life. Like you start to see trends, and then you think, and then you put those people in colder environments. How does that affect them? We're not in a competition for upper cervical being a solution for vascular health to the brain. We can dominate that discussion by using their research and their studies and our results. Got it? Doc, cervical flexion. Okay, let me touch on that real quick. So here's the other part I thought of. What age group did we see the majority of disc degeneration occurring in?
50.
Between 50 to 60 years old is when it really kicks into gear. And that's also when we saw the curves being lost. Do you remember? So people are out of alignment, losing curves, weakening discs, showing its highest prevalence between 50 to 60 years old. If you have elongated styloid, do you remember what the study said? Worse with flexion. Well, that's intentional flexion. What about if you're losing the curve and you have unintentional flexion? It all matches together. Yes, sir?
I was just going to mention two things. If you're curious in looking at a lot of patients if they've had a CT scan taken, a medical one, you can look at the axial slices and just go down to the level of the atlas. And since on a regular CT, bone is white, right? If you have the atlas transverses, the styloid will be just these white little dots, you know, a quarter inch in front of the atlas TP. If you're curious, you want to back up, so I know you're saying it's not always easy finding these things, but if your patients have CT scans, you can use that as your backup. The only other thing I was going to say to Stan was that there's some people that we're seeing, like, you'll see the styloid ligament bent. So if it's coming down and then bends in front of the atlas transverse, when you're talking about causality and how long it's been there, I mean, they could have had an atlas twisted from an early age, and that goes back to whether it was genetic or it was ossified over time. What I was saying a second ago is some of them will actually bend over the TP, or that TP is pushed into it potentially for decades, you know what I mean? So it's very kind of interesting, and I think it's just something that makes it that much more important, you know, in terms of wellness and getting kids checked. So these things, it gives you chronicity of time, how long they've had the problem, and just how significant that is, you know what I mean, from a young age. If they got, I mean, who knows, birth canal, birth trauma, you know, like it's pretty intense. It's really, really important stuff. This is awesome.
So much fun to talk about this.